Good evening, and I'd like to extend a very warm welcome to all of you joining us for this webinar under the Sattva Knowledge Institute's Touchpoint series. This series of webinars is designed as a set of knowledge-driven interactions with members at Sattva Knowledge Institute, along with eminent sectoral experts. And during these interactions, we introduce our audience to key topics where we see interest and traction across the ecosystem and provide them with not only information, but help with making decisions in an evidence-backed manner. I am your host today. My name is Lakshmi, Sethuraman, and I head the health practice at Sattva Consulting, where I lead all of the knowledge work that we do out of Sattva Knowledge Institute and advise on many of our health projects. For today's discussion, we're going to be focusing on a very important topic of perinatal mental health and how we can incorporate this into existing health systems more effectively. Our expert speaker for today's webinar is none other than Dr. Hema Divakar. Dr. Hema is the CEO of Asian Research and Training Institute for Skill Transfer Artist and is a consultant OBGYN and medical director at the Divakar Specialty Hospital in Bangalore. She has also held the presidency of the Federation of Obstetrics and Gynecology Societies of India, FOGSI, in 2013, which has 32,000 specialists on its roll as members. She is now the FOGSI ambassador for FIGO, which is the International Federation of Gynecology and Obstetrics, and received the FRCOG Honorary Fellowship by the Royal College London. She's also the vice chair of the GDM working group at FIGO and FIGO executive board member. Dr. Hema is also the governing council member of the South Asian Society for Menopause and national coordinator for FIGO FOGSI postpartum IUCD program. She is a thought leader in the maternal health space and brings forth not only years of experience as a practitioner, but is also a very passionate advocate for holistic well-being of women and mothers through strengthened health systems. Thank you so much for joining us today, Dr. Hema.
Namaste and thank you, Lakshmi.
Really looking forward to your insights. So, many women experience changes in their mental health during the perinatal period, the period during pregnancy as well as post childbirth. And poor mental health can negatively affect women's health and the well-being of not only themselves, but also their babies and families. And often these mental health concerns go undiagnosed and consequently untreated. According to WHO, in India, 20 to 33% of women today suffer from some type of mental health disorder during pregnancy and after childbirth, and that roughly translates to 1 in every 5 pregnant and new mothers. And this includes a range of mental health concerns across the continuum of care. So therefore, adopting a preventive and promotive view of mental well-being is critical to make sure that every woman in this period is equipped with the right information and awareness, is able to seek care, and has the requisite support at the appropriate time to make sure that she is both physically and mentally healthy. So one of the opportunities to actually do this is through the maternal and child health services that have been institutionalized very well today and during the perinatal period specifically. Practitioners, which include frontline workers, nursing staff, gynecologists, pediatricians, amongst others, that are engaged in the provision of maternal and child health services in both the public and private sectors, have multiple points of interactions with women during this period. And in particular, frontline workers and nursing staff and community health workers are frequently engaging with women. And there is an opportunity here to look at integrating mental health care services into the existing system through these service providers. So recognizing this opportunity, Sattva Knowledge Institute partnered with artists as well as the Karuna Trust team to undertake primary research and to understand the knowledge and attitudes and practices of service providers in this regard. We looked at about 228 service providers across different states, including Madhya Pradesh, Odisha, and Karnataka, as well as across public and private sectors. We did this through surveys, focus group discussions, as well as key informant interviews. And insights from this research, as well as the recommendations for specific stakeholders, have been captured in a report that we published as part of Sattva Knowledge Institute. Through today's discussion, we will also be using these insights and findings from that study, and you can scan the QR code as well as use the link in the chat box to access these reports as well as the detailed findings. So, given this background and context, Dr. Hema would love to maybe start with one, if you can talk about, perinatal health itself. I know that, our participants come from a variety of disciplines today, including nonprofits, philanthropists, as well as providers. And it'll be great if you can talk about what really is perinatal health, and two, particularly in the Indian context, what are some of the drivers of mental health that then become risk factors for perinatal depression amongst Indian women?
Right. Thank you, Lakshmi, and thank you, Sattva, again for bringing us together on this very important topic. See, there are two aspects to this touch point, how you have labeled it: perinatal, mental health. So mental health, pre-COVID and post-COVID era, it has journeyed from being a stigma in the pre-COVID. So I have to say, with more than 30-35% of the entire population being in a mental turmoil and everybody recognizing the importance of mental health, we've come a long way in just the last 2 or 3 years with, so much happening around this issue. The other word here is perinatal. Many people will not know what perinatal is, though it's so simple to understand. When a woman undergoes menopause, and I'm in the perimenopausal state, so then everybody can relate to it. And menopause, so they're around it. Okay, natal, when you can so easily relate to prenatal, antenatal, postnatal, which means pre-pregnancy, during pregnancy, and beyond pregnancy. So that natal word refers to the peri-pregnancy status and immediate post-delivery status. So when we say perinatal, it is the health of the mother and the newborn. That is the chunk of perinatal care, as we would call it, to give the best to the mother so that the best things can happen to the programming of the baby in her womb, so that the generation next can be the best with respect to health. So the perinatal mental health, that is around this, aspect of a woman's life, what does it involve? Who gets stressed up? Do we actually recognize it or not? Are there really risk factors that some women are prone to it? Okay, so there is, a whole spectrum of risks across the female gender, because this is perinatal health. You see, so men can't become pregnant, it's only women. So we're talking about women's mental health in short. So whether it's rural or urban, the pregnancy itself in this new era is bringing about an anxiety. Because many would have had dozens of children with ease and, not even taking it as a risk factor. Now we are not only talking about pregnancy risk, we're talking about risks for perinatal mental illness. So to say, in the touch point topic today. So the risk factors, when you say, women who is not being able to conceive easily, spend loads of money in the preconception and for getting pregnant itself, there's a huge anxiety in her, which is also influenced by the immediate family and the social circles around her, to be the best performer. Don't do this, don't do that. And there's so much pressure that is put on her. And then when she comes to the doctor, there are many aspects that the institutional care can check on, and ignorance is bliss on the other hand. Don't check your BP, you don't even know you're hypertensive. Don't check your sugars, you don't know you have high sugars in pregnancy. But today, as per the standard protocols, when everything is checked, inclusive of the ultrasound scan, they can recognize that there are some malformations. Oh, God forbid, my child should be healthy in all respects, and then there may be a twin pregnancy, which many women in the past never even knew until they delivered the first and the second one also came. So that was the situation about 50 years back when everybody did not have the scanning. So the pregnancy risks itself, which we call high-risk pregnancy, whether it's high BP in pregnancy, high sugars in pregnancy, there's multiplicity, child not growing well, child growing too much, all of these by the new era, technology-driven tests that we pay attention to, which is of course good, both for the mother and the child, that is for perinatal care, these things are good, but the anxiety which precedes the performance of these tests, what if something is wrong? That is why, the mindset of preventive care is not existent in our country. They say, no, till something happens, let me just not bother about it. So now the mindset is changing. So that's a huge, risky situation medically speaking. Postnatal, again, the influence of the cultures, the families, mother-in-law's team saying something, mother's team saying something, everything gets mixed up in her head. And whether, the perception that this is an urban fancy lady, she may not even want to feed her child, etc., which is not the case, really. But so much mental pressure is put on her that whether she can be a good mom, simple things like this cause a huge risk for the well-being of the mother and her mental status. Quite apart from the fact, slowly, we hope that this will, slowly get into the background as the years come by. The gender of the newborn, the sex of the baby, many parts that also adds hugely to the risk for the depression and other mental situations. So all the way through, you would recognize whether it's a social factor, cultural, economic, nutritional, risks in pregnancy, or the kind of environment that she lives in, the demands of her work pressure, and the caring for the first one when she's in a nuclear family. You name it, and she has it as a risk for her mental situation.
No, I think you've touched upon very important points, Dr. Hema, right? I think just maybe to paraphrase what you're saying, it's not just, individual factors, but there are so many social, cultural, economic factors that are responsible for, or some of the drivers or constitute as risk factors. I think the marital and family factors that you pointed out are, again, play a very, very large role here. And would, again, for the audience, Dr. Hema, what for stakeholders that are working in this space, right? So for providers, program managers within nonprofit units, frontline workers, and so on, that are working with women directly, and not necessarily in the context of mental health, but really in the overall, caregiving for women. What are some of the signs that they should be vigilant for, right? Like, how do you identify women who might be at risk?
Okay, so you have to look beyond what meets the eye for this situation, for sure. You've got to be sensitive enough to tap from her that this could be an underlying problem, and many times it can manifest in many different bizarre ways, and you may at a glance, on the top of it, you may just think that she's making it all up, which is not true, which is, she keeps on consistently telling about some chronic pain, and she's never happy with anything that you do, but you never even, go beyond the technical check that, which is now slowly the attitudes of the providers are also changing, because they know that this could be an underlying fiber in the well-being or ill health, either way, for the patient and the pregnancy situation itself. So there is, provocative questions, if I may say, or to probe as to what may be beyond the standard, signs and symptoms that you will ask, because these are, the silence speaks louder and more than the words. You can make out sometimes by her body language, and sometimes with the way she responds. And the fact is that you need to pay attention to that. There is not many things may not be even verbal, but you have to tap into that. You have to ensure confidentiality, and you have to be very reassuring, and I'm there for you kind of an attitude. only then she will open up and say. So there are no glaring, signs and symptoms that one would think, except for the fact that she may not be really voicing out what she is feeling unless she has a trust factor and a rapport with you. So to build that, that's the bridge for the signs and symptoms to even reach somewhere near there. Otherwise, even the providers think, we are doing all these tests, we are making sure she's okay, we're making sure the baby is okay, and that's not a good outcome in a technical sense, but not really, for the mother and the family as far as the mental peace and the health is concerned. So there are many angles to this because culturally, spiritually, and contextually, they are from very different. I mean, you may not even sometimes recognize issues like domestic violence, for example, or the interpersonal relationship issues, which may be leading to something which is totally unconnected when you get such a symptom or a finding in a patient. So it is a very subtle, sensitive issue unless the capacity of the caregiver is built in that manner and the soft skills of compassion and empathy are integrated into it. You will never be able to define it by sign number 1, 2, 3, symptom 1, 2, 3. That doesn't hold for mental health issues for sure.
Yeah, and I think that underscores, therefore, some of the nuances that are needed here, Dr. Hema, very importantly, because it's not something that you just intuitively are able to, let's say, provide. It really requires a discerning eye. It requires some level of that training and so on to be able to identify this and then address it in an early intervention kind of a manner, right?
Sure, we never even thought, Lakshmi, that, ages ago, our teachers or their teachers never thought that a course or a module on communication skills need to be introduced for healthcare providers, because we are always expected to, feel for the patient or be in the patient's shoes and reassure them and recognize what they would be going through, etc. But there's no role modeling. It's not happening. So even simple things like how to break a bad news and how to deal with an angry or a frustrated patient. These are all integrated, if you say, to the mental health issues, which need to be very delicately handled. So I agree that we need to proactively, tune them into not only thinking, but executing in the manner that it should be.
Absolutely. No, absolutely, Dr. Hema. And I think that, just segueing maybe into the next question, and it might be useful to hear from some of our audience as well and people that are working in the maternal health space in terms of what really are some of the challenges that you may have faced in providing mental health support to mothers as part of your work, right? I think it'll be great to hear from the group, and then Dr. Hema can also comment on it. Please do, go to the Mentimeter poll that is listed here, and your answers will come up on the screen. But it'll be great to hear from our participants on what really you have seen, right? Like, what are some of the challenges that you have seen in incorporating mental health support to pregnant women and new mothers? Give it a few minutes for the answers to come in.
Yeah, and Lakshmi, it is for healthcare providers, it is often a case of basic roti kapda makan, right? You need to make sure that her basic health is good. She doesn't lose her life, and then the child will be at least born life, and whatever it is. So those kind of issues, maternal mortality, infant mortality, talked about in a big way in the entire country and in the entire globe, that India is this, that, and the other. Now that we have come, a significant way ahead, we can afford even to ask such questions. Because, they say that where is the question, nutrition, mental health? Come on, you have not done the basic things for the patient, and she's preventable deaths you're not being able to handle, stillbirths you're not being able to handle, and what are you talking about? So now the stage is set to, refine these opportunities and the touch points, which could be challenging, of course, as the question that you have posed, but we have to use these as opportunities to do, more than the best for the women and her family. So this is what we call a positive experience for the patient, because they need to shift their focus from anxiety, depression, etc., to really the joys of motherhood, as the cliched call would go.
Yeah. No, absolutely. I think we have two answers on the chat box, and I think more are coming in as well. I think there is a sense of lack of training. There's a sense of limited, let's say, private spaces for mothers to share this freely. There's also a sense that if and I think that's linked to the private space as well, which is if a family member accompanies, then there is a hesitation in being able to communicate. And I think a very important point, which is there is no basic even awareness that they are going through something like this, right? Especially in rural tribal settings and so on, as as we have on the chat box. And I think what we maybe Dr. Hema, it might be great for you to come in here, is why do practitioners or organizations today that are working in mental health care, why do they face these challenges, right? And what really is challenging in terms of being able to provide these mental healthcare services? Is it more, let's say, individual, as people have pointed out here, in terms of training, lack of training, and so on? Is it more systemic in terms of the policies that need to be there, or let's say potentially funding that needs to be there, and so on? I think it'll be great to hear from you on that, and subsequently also some examples from your experience in terms of what has worked, right, for providers to be able to support women in their mental well-being during routine care.
It is not yet perceived as one of the important points in standard of care. It's a must-do thing, because when we define health, when we say physical, mental, and spiritual well-being, it is there as a definition, but it is not getting implemented. And I agree with all of these comments which are displayed over here, because yes, the too much stigma around mental health. Even today, everybody wants to believe that they will themselves somehow self-correct and overcome it. They don't want to seek help, and they don't want to make it obvious to the others. And when you say, the rights of the women, we put up their boards, rights and rights of the patient, and then responsibilities of the physicians, etc. They are only sitting in the boards, because when we did the quality training initiative for groups of paramedics in various private sector hospitals, there was a particular protocol that they should follow called respectful maternal care. And that involves a lot of these issues about the private spaces, the confidentiality, and allowing the birth companion, so on and so forth. But believe me, nobody could relate to it, not even the patients, because when we asked about the previous experience, they thought it was all normal to be taken for granted and to be treated in the manner that they were treated, because some of them are so benign, as I would call it. The demands are now growing because of the awareness that, they deserve at least this much. And I really think every girl, every woman deserves the least at least to say the least, that at such an young age, she's fulfilling a physiological job, if you may call it, her duty to propagate the human race ahead. But it's shrouded with so many risks in perinatal mental health. When we talk, it will be failing in our responsibility if we do not respond to that. Coming to the policies, see, not only in mental health, but there are several other basic things like Anemia Mukta Bharat Ka guidelines and policy, diabetes, and the gross thing, how that policy gets implemented into practice. how the knowing and doing, the gap can be bridged. Here again, training on the topic, etc. And it becomes sometimes, Lakshmi, like nobody's baby. Who is to talk to her about that? Patient may not open up on her own, but who is, going to support her for this? Who's going to raise this topic? And that's the patient who's never ever been questioned around this, think that this doctor or this healthcare provider is a little weird, not just asking me whether everything is okay. What do they mean everything is okay? Because in that sense, if that is the way you start broaching the topic, even sometimes they do feel awkward, and they try to just shy away and think that our behavior is odd rather than, so it's such a delicate mix of so many things around this. So if you can just read this out on what we actually found, it'll be really, adding value to our conversation.
Absolutely right. I think even through our study, we found these. I mean, this basically came in terms of challenges that women face, and I think a lot of this was something that people spoke about as well, and we pointed out earlier. One is, I think, just the basic lack of awareness, right? Like somebody else pointed out earlier, women think this is normal, right? They don't even believe that there is
absolutely
difference. So the awareness to say, yes, I'm going through something and therefore I need to seek care, I think is missing. Of course, familial support was another big challenge. And I think the stigma around mental health continues, right? So I think these are the top three factors from a women's perspective that was faced. And I think from a provider perspective as well, if we can you,
one important thing when you say the family support, always, even in the literature, you will come across in low middle income countries, it's a mother-in-law and daughter-in-law issues. And so we often, refer to as the female gender to gender competitive, clash is there because, the previous generation want to do it their way. The mother's family wants to do it another way, and the patient gets sandwiched in between the two cultural contexts, whom to listen to, and the new era of the patients who only listen to Dr. Google and their opinions on the social media and the friend circle, etc., are considered arrogant or stubborn. See, I told you this, and you didn't follow that, and that's why this endpoint you have reached today, and it is made to feel guilty on top of all the risks that she's undergoing. So nobody says that the men in the family or the husband, if they're not supportive also, they will not openly speak about it. They will say, no, everything is okay, because they feel that, okay, something financial support, or at least we are living under the same roof, that kind. So it is such a complex, mix of things when it comes to how the family is looking at it. Is her space given to her? Is her opinion valued?
Yeah.
Can she, with courage express what she's going through? This is not happening in our experience in practice. In fact, when we did the first study about 12 years back about postnatal depression, that is the time our own setup got sensitized to the fact, hey, these are the questions which we're asking in pregnancy and also across post-delivery. And there's an overwhelming 40% of the women whom we never even, we thought 100% of them were okay, if you think at the face of it, because we never even bothered to look into this aspect, you see. And 40% means nearly half of them, had something to say about many questions that we were made to ask as a part of the research project. That means it's there. It's like a hidden hunger. It's a hidden mental health problem, but it's not surfacing because you're not put it out.
Very true. And I think the point you're making, Dr. Hema, the familial support, how do you also bring in awareness? So it's not just about, mental health itself. It's also about breaking the stigma, looking at, the larger components around that, looking at gender norms within the familial situation and so on, which are also critical to be able to address this issue, right? Yes. And I think if you can talk also, Dr. Hema, a little bit around from a systemic lens, right? What can be done? So, for example, I think you had mentioned earlier about creating some of those safer spaces, usage of some, the tools that you used. I think some
Yes.
examples that you can talk through that, I think will be very
Yes, because there was also something came up that there is no confidentiality, there's no privacy. See, today the girls and women, whether from rural or urban space, all of them have the smartphones, and that we would think as on today as the most powerful tool we can use for n number of things. Okay, so what we generally do is, there's a whole questionnaire, like it's called Fit to Be Mom, and then even ahead of stepping into a consulting room, the habits of alcoholism, smoking, domestic violence, this, that, and the other, what is actually cannot express in the in the four walls of the clinic, where either her partner or her family member or the in-laws or whoever, it's not only that constraint, but also the staff around the consultant, or maybe in a public setting, some students around that. She doesn't want to say any of these things. So we get an idea of where we are even ahead of her stepping into our chamber. We can, then gently go along the points that she has mentioned as her concern, and then try and rectify that. So the digital space, the digital media, the awareness programs, which can be, in a very novel way, because technical jargon and a whole lot of things, it will create more anxiety, perhaps sometimes. You do much overwhelming information. That is what is also creating a problem, because they want to know everything that's happening to them in pregnancy, and they read between the lines and they get more confused, more anxious. So technology is playing that role also of creating a more havoc in their own mind. But the same technology, for everything there is two sides, use and misuse. So the same technology can be used in a novel way. And also when she has a panic attack, there's a helpline. They can reach the concerned trusted healthcare provider. So at least she knows she has an option. She knows there is somebody for her. Even these things make a lot of difference for the mental well-being, for sure. So many of these which we have experimented within our own practice, we have now percolated into rural areas. In fact, or many of the rural women, when we've set up the clinics for girls and women, the digital connect by a video consult every single day from some remote place. 5 years back when we started this, and 2 years back when we enhanced this, there were some pockets where the women did not possess a mobile. They had to seek the help of a neighbor or a husband who would grant permission to use a mobile. And now the scenario has changed. And as the time goes by, the younger generation, they may not have one, they may have two mobiles. So that is the kind. And there are certain novel devices, which will rent out to the patient in pregnancy.
Right.
And she can use it at home, and the reading comes on a WhatsApp message to the doctor. Doctor gives a thumbs up, telling her all is well. Then she has less fetal movements. Then she places the device, and it gives an excellent graph. And we say, don't worry, don't rush to the hospital. So there are things evolving where the technology also can come to overcome certain barriers, as the privacy, confidentiality, the time that is allotted, something to do with AI, some prompt answers which are already given, some helpline, situations where there is enough and more support. So these are all buffers which will really change the face of what could be the scenario for mental health issues in the years to come. Yeah, it is going to escalate the issues around mental health, because we are recognizing, we are paying more attention to that. The more you probe, the more you'll recognize that there are more girls and women in it. Okay, and perinatal mental health, now that from 5 children, 3 children, 2 children, 1 child or no child, even that decision making is a mental health issue. So perinatal health is, is emerging as a key factor with the mental health issues. So I'm sure that in the days to come, the problem will escalate, but we will have the solutions also coming. That's how we have to look at it. We've spoken enough about the problem. Are there ways around? Are there new methodologies? Yes, certainly they are, if we use it in an appropriate way, and it will be hugely beneficial to the care seeker and the caregiver as well.
Absolutely. Absolutely, Dr. Hema. And I think that, thank you for sharing that. And I think some of the findings that we found as well, right, through our survey was very interesting, right? It seems that I think the one of the core things was that everybody was actually interested in, doing this. Everyone recognized this as a problem through their daily practice. And I think what everyone expressed the most was, can we have enough training, right? Can we have the right tools? Can we have the guidance to be able to do this better? So I don't think, at least from a provider standpoint through our survey, and this was uniform across states, is that it's not that there was any resistance or even, a lack of recognition of the problem. It really was to say, yes, I recognize, I know that this is there. How do I, provide the right, can I get the right training to do this better? Right?
Yes.
Which was very interesting, I thought, Dr.
And
Hema.
also when we know that there's an overwhelming load of patients and there's constraint of time,
right.
A quick checklist kind of a, training. Everybody in the team, right from the frontline healthcare providers, semi-skilled providers, everybody, just yes, no, some checklists also, if you make them fill, you have a sense of where we are going. So the training is not rocket science. You don't have to be a full-fledged psychiatrist or psychologist or therapist for that. So at least a quick check to recognize that this subset of patients need more care. That is so very crucial, because unless you filter them out, then you can't pay attention to the whole, 30 million pregnant women around perinatal period. Out of that, maybe 1 million will deserve this care. So you pluck them out and, stratify them as these are really needing a lot of care. Okay, take the support from the specialist. This, you can talk to her and handle it yourself. This can be perhaps handled by the support staff itself, because like breastfeeding issues, for example, which is making her feel very depressed, the paramedic can herself be trained to support her and give her the right guidance. Myths and misconceptions can be busted. So I think this research is very, very strongly valid, because the training, which is not a rocket science, which can be simply done across all levels of healthcare providers, is the easiest point we can plug in. Support from the specialist. It's always said that God cannot be everywhere, so he made mothers. So specialists cannot be everywhere, so we have to make some skilled providers to quickly check on the checklist and identify these and private spaces, etc. Yes, technology can overcome that and establish guidelines and practices. Given the country like India and mental health issues, to establish a standard protocol is going to be a challenge in itself. But we will be making our own attempt through professional organizations to at least move a couple of steps forward to see to it that we can do better than what we're doing right now.
Absolutely, Dr. Hema. No, thank you so much for your thoughts there. And I think this is a good segue into our next section. We're also limited on time, and we do want to give some space for questions as well. But I think Dr. Hema, again, right? So the while we've spoken about individuals, actors, and citizens, as well as the women themselves, and so on, how can we look at system level interventions to make this work, right? And particularly, what are some of the pathways to enable or look at integrating this into perinatal health systems itself? And now with the focus on mental health being significantly higher, there is more recognition of this in a mainstreamed way, like you pointed out as well earlier, post-COVID. What are the actors, particularly, let's say, philanthropy, civil society actors such as nonprofits, as well as providers, right? What is it that they can do in order to enable this? Would love to hear your thoughts on this, Dr.
Yeah. See, the limitation is that because we are working in silos. Okay, when we are talking about the touch point of mental health today, anybody who wants to support this cause and facilitate all of these solutions that we said, for example, we have to also holistically look that when we are paying only attention to her physical health and did not pay attention to her mental health, it does not mean now we have to pay attention to mental health and forget the physical well-being, right? So it has to be integrated even in that sense that you get one opportunity, one touch point, and the perinatal is all about delivering in an institution which is, sky high, and it's the best possible ever in our country today. So that is a huge opportunity. So if you invest in a whole series of rich human resource, create a cadre of counselors, not only counseling for mental health, but that is the beginning of striking a rapport, because all those skills they'll require, and they can along the way tap all these mental health issues that we have discussed today, but also pay attention to 4 or 5 very important make or break points in her physical well-being as well. So in an integrated way, it will be the time, efforts, and energy well invested if we bring in that. The second thing is that capacity building at all levels. Okay, within our peer group, within the frontline healthcare providers, within other segments of the society, whether it is not only that they don't have to, pregnant women who are in major corporate sectors, when they say wellness of our employees, they have to pay attention to the mental well-being as well. And even, in the colleges and all, they have now had the career counselors and counselors as a routine. So this has to shift even into the space of the perinatal care, wherever she is, whether it's urban or rural, whether it's clinic or office, whether it is home or elsewhere. It needs, an approach where whoever can, support this. Believe me, once the mental health issues are at least addressed in a reasonable way, what we call as a baseline, it really, really forms a very strong foundation for the positivity that she experiences in the perinatal period, and the courage that she will have to face certain setbacks, if any. So that is the way we look at it. And the issue in every single case, even if the physical health issues are not there, a reinforcement of how she will deal with challenges, if any, and supporting the mental well-being, I think is a very, very strong foundation for preventing illness and promoting wellness.
Yeah. No, I think, again, valid points, Dr. Hema. And I think maybe just to add to what you're saying as well, right? I think, and then responding to, also strengthening, let's say, capacities of the health workforce, like you said, creating those specific cadres, or even supporting existing cadres with the right tools and the capacity to be able to deliver this care. So I think that's an area that philanthropy can focus on.
Simple tools. Simple tools. They need to be good communicators. That's it. Just little things. Even that goes a long way, because, we should not make it feel like you need a very great level, high level specialist, and then, this much, and then to get a degree. No, any human being can be cadre-wise segregated into how they can support. Yeah. And this capacity building support, if it is offered in a massive way, then even early recognition that somebody in the family is having this mental issue will be a very big plus for, preventing a disaster in the future.
Absolutely, Dr. Hema. And I think the other, point is also that, some of these models today are working, right? But at the same time, it's not really something that, the community knows about. How do we also think about investing in evidence, right? So if there's a need to document this, a need to look at this in a structured ways, and some of this evidence be disseminated to the larger ecosystem so that it can be adopted and scaled up as well. And I think that's where the philanthropic ecosystem perhaps can play a stronger role in supporting with investments here. And I think the other piece as well.
Because we always say, Lakshmi, that healthcare and technology needs to get married, and the big data can only come in with the tech support. And if it is done with ease for awareness, for capacity building, for big data collection, and learning our lessons from there, all these, it's like, as I said, it's like an orphan. Who will do it? So if the funders or philanthropists are sensitized in a manner that this serves a bigger purpose than what you would think. It is really, it'll make them feel it's worth it as well.
Yeah. No, absolutely. And I think, looking at this, like you said, these are simple things that can be integrated. It really is not, for example, doesn't add to the burden of a frontline worker or or a specialist. And given how receptive they are today, the time is also ripe to, include this and bring this as part of the mainstay. And I know that some work is happening already, by organizations like NIMHANS, where they're looking at some of this capacity building work. Some state governments have already taken the lead in doing this, but more needs to be done as well.
That's why I said, Lakshmi, when you said about the policy for mental health and nutrition is already there in place. But the implementation gap is something which we need to be really serious about, because these are very, very low-hanging fruits which will yield a lot of positive results. Both of these aspects, nutrition and mental health, which is, and also the fact that it's so easily doable and it can be scaled without compromise on a quality. I think we should be a little more serious in our attempt to make this happen.
Absolutely, Dr. Hema. And I know that we have only a few more minutes. I have one last question for you before maybe we can take questions from our audience, which is that particularly you spoke about the specialist piece earlier, Dr. Hema, and if you can touch a little bit upon how do you think about that stepped care model, right? And how it can actually address these gaps in an effective way, because this also then can potentially go into a policy level tweak as well, right?
See, Lakshmi, to give you an example, not that only with the mental health piece that we needed this, but as clinicians, as gynecologists, the issue of diabetes in pregnancy, for example, every international forum that we go, it was spoken about that, yes, this is a pregnant woman. You are only taking care of her pregnancy. But what if her sugars are high? Okay, send her to a counselor, send her to the next chamber to a dietitian, send her to the next chamber for a lifestyle expert because she needs those exercises. Send her to the fourth chamber to the diabetologist. Then she will be properly taken care of. We said, no, this is not possible in our country. Why? Because out of 30 million pregnant women, there are 5 million pregnancies with high sugars. And we have only 1,000 diabetologists. Who we will send? Where we will send? The nutrition specialists are like non-existent. Can we take this responsibility on our own shoulders and then get her to the level that only the last few who do not come under control, early diagnosis, the diet advice, the lifestyle advice, and the medication, all of this you take her along. And the last piece where she really needs a specialist advice, 2%, 1% go to them instead of thinking that 50% or 100% will need to go. The same way we build this step-up approach to the mental health, and also because you know that, as I said, the traffic signaling green means, okay, this is, it's a very temporary small setback and we can handle it ourselves. Then amber, okay, flag this a little bit here and there, and you may need to spend more time with her and reassure her in between with the technology support. And then if it's a red, then we seek the help of a specialist. So in that way, if you layer it, it is practical and it will be feasible. Otherwise, it becomes very overwhelming. Everybody cannot know everything, especially in women's health field. Everything that is experiencing, it's a knee pain and orthopedic health guys to come. Diabetes, then we have to come. Cardiovascular accidents, which are now happening in cardio. How much can you do? So you can at least offer the preventive care, early recognition, and basic care. That much if you do, 80-85% is taken care of. Because it's not only the pregnancy, everything else. So that is why the building will, though it looks overwhelming, once you start inching your way towards that, you will, figure out that, yes, we'll be able to do it.
Absolutely. No, I think very valid. Thank you, Dr. Hema. And I think maybe we can open for questions for the next 5-7 minutes. And maybe Yashasvi, can I just request you to read out the existing questions already, and I would request the others as well to leave your questions on the chat box, and we will take it over the next 5 to 7 minutes.
Absolutely, thank you. I think we have received one question so far, and Dr. Hema, you can maybe talk a little bit about the fact that there is hardly any acceptance of such a thing even existing. The concept of mental health itself existing in rural areas especially is a challenge. And the question here is about how can we, at a mass scale, at a community level, actually focus on generating awareness and also, in some sense, this being integrated within state systems where the awareness around mental health is, part of what systems already are working on.
Yes. So thanks, Yashasvi. As I said before, that if you only go and try and think that in the rural areas and the communities, you can give your practical knowledge or otherwise only on mental health, it's not going to work. Because they will have many other problems around it. So when you tackle the other problems, what I'm saying is bring mental health also into the center stage. That's how you strengthen the systems. That system is not going and only attacking because there'll be no takers for that we are the mental health specialists, or we are trained in counseling for mental health and we'll do this, that, and nobody will be coming for it because they will all think that that stigma, yes, that factor is still there. So like when we started our work on HIV/AIDS, we called it a well women clinic. And all sex workers only were coming there. We did not say that it is for HIV/AIDS. We just labeled it as well women. Something for women is there, and we established in such an area in Majestic that we knew that who would come there. Okay, so that way, if you say, okay, this is a pregnancy care clinic, this is a special clinic for high risk pregnancy, so whatever. So into that, the piece of mental health should become a standard of care. That is where the systems will be strengthened, because that's the only way it's going to work. Because after all, this lady, you're not looking at her in isolation only from the point of mental health. You're going to wholesomely treat her, in which you were not hitherto paying any attention to mental health, but now you have sensitized yourself and you sensitize your whole team, and they're all act in sync with what you're trying to approach and how you're trying to approach.
Absolutely. I think we do have a few more questions coming in. And I think the next question, Dr. Hema, is very closely linked to what we were talking about earlier with respect to strengthening systems. Mm-hmm. And I think this is something we've touched upon in the report as well, which is how can we look at actually building linkages such that there is also support that pregnant women themselves have when they are also facing challenges, or they recognize that there is a need for them to avail psychosocial support, such that they know where to go when they require help outside of these systems. And I know you have also talked about building those linkages within communications with women and families as well. So if you can maybe talk a little bit about at a health facility level as well as at an individual level, how these linkages can be built with specialists.
This, is more practical, more feasible, building these linkages in an anonymous way through the helplines and through the digital platforms, because barrier can easily be overcome, because there are so many UIs available now with 10 or 12 languages are a given thing. So she gets to interact, either in a passive or an active manner through these helplines. And we had instituted the Janani helpline, where anybody could approach and give their choice of the language as well, so that the doctor or the counselor can speak to them in that language. So there are a few novel things which have been tried as a pilot in the concept, which we were not wrong in thinking that this would work, because sometimes it's very fractional. It's not like a great mental disease that you'll be having. That component will go to the specialist, but most others which are transient and perinatal mental health, that means it's related around the well-being of herself and the outcome for the child, and also the mode of delivery. They may be frightened as in the new era on normal delivery, where we have to suffer with so much pain, this, that. So the requests are now getting reversed to an elective C-section, for example, because that much apprehension is there, even for, ultimately she has to deliver. So then that is sitting on the edge in the last 4 weeks. So it can be simple things like that, which can be handled with some more information, myth busting and reassuring talk. And so I guess for the numbers that we need, and also the language of the rural community. The examples that they will understand will be far different than a hi-fi metro city ivory tower doctor. We can't even perceive what their social circumstance would be and what would really work for them in their dynamics of the family. So it is largely that we have to rely on a quality delivery of the mental health care to the digital space to reach the last mile. That's the only big way it's scalable, because this is not like you will need her to come to the clinic to do an examination, to do a blood test, to do this, to weigh her. It does not need. So this is the potentially a biggest opportunity for using the telehealth and the digital connect for doing your best.
Thank you, Dr. Hema. And I think we'll just take probably one last question and we should be closing in about a minute. But just on the same context, building on that further with respect to social and cultural settings, I think there's one other question on the fact that often women lack agency in decision making. It's often the men in the families, the others in the families that are making these decisions. And so, considering that this is a reality of a rural setup, should women solely be at the receiving end of these programs or these initiatives, or who else should be actually part of these, so that we're bringing those that are actually making these decisions for women as part of these conversations and engaging with them?
No. Even for a simple thing like contraception, we have, have had the experience that unless the family is taken into confidence, then, what she agrees by herself in our chamber may not hold good unless there is a buy-in from the whole family. That is still a reality and it is a context. And to keep the peace of the family also, we would also prefer that if we, empower these women in her own right to make her own decision, that's correct. But how it has a ripple effect on the family, so that everybody, even if there is a conversation that has to happen and the buy-in that has to happen, and there is a little bit of give and take, the family structure, you cannot in isolation, because if you inspire her so much to rebel, it is going to be a real problem, because you get into more of a soup and afterwards you cannot help her. That's been our experience also. Hey, no, you have the courage, you do. Sometimes even when we do the health and hygiene program in the schools, my junior doctors, they have really created some out of the box thinking in those girls, and they're really, the mothers are coming and complaining to us, what have you done to them? So I think the women should not be targeted for sure, because she's bearing the brunt of everything. She's taking all the risks that's possible. The least you can do is to support her in every which way. And there are some families, this is a typical thing that families do not support. There are some families, there are many families. Men are also very supportive, and nowadays, the equations of the mother-in-law daughter, it's definitely the dynamics are changing, but still we need to respect if there is, a clash between their thought processes. We have to take everybody into the fold. For that, you need your own maturity. To say, and many of them, who are into this religious, spiritual activities, they are a little bit more mature, and there are sometimes the language that you speak, they will just dismiss you and probably go to some other doctor. That is what is going to happen if you are not inclusive. So we do believe that the family, because
has to be family.
Once upon a time, the husband or any male member would not even enter a consulting room. They were, thinking that totally they have nothing to do with this. But now they have been more and more engaged, and it's our duty to engage them as well.
Absolutely. And I think it's the provider push as well that kind of makes that happen.
Yes.
So thank you so much, Dr. Hema. I know we are at time, and, very illuminating and interesting discussion, a lot of food for thought as well. I just want to close by saying that I think one of the things that we have realized through the course of this discussion, as well as the survey that we did, is that we cannot expect women well-being to be complete without mental health care being integrated into it, right? So, and I think that I know there was a question earlier about funding as well. So how do even funders that are thinking about women's health overall, or even maternal and child health, look at integrating mental health care as part of the overall program? Because mental health care is not separate. It really has to be designed and included as part of these services. And I think that's what I would urge, all of our audience as well to take with them. Please do, give us your feedback. I hope you have found this session useful. You can also look at the report that we released together with Artist and Karuna Trust as well, using the QR code as well as the link on the chat. And thank you so much for joining us today and giving us your time. Thank you, everybody. Thank you, Dr. Hema, for your time and insights. Really appreciate it. Thank you.
Thank you very much. Namaste. Thank you for the opportunity. Thank you.